Welcome to the Health Services Research Association's final webinar for 2018. The webinars are one of the key activities of the association in terms of disseminating members' research, promoting good health services research. And so if there's anybody participating today who has an idea for a topic, potentially a guest speaker, or would like to present their own research, then please get in contact with Sarah Green, the Executive Officer of the Association. One further unashamed plug is for our other key activity, which is the conference, the Health Services Research Association Conference. It will be coming up in December of next year and will be based in Auckland. And the theme of the conference is on health inequalities. So I encourage people to get their research to a point where you may be able to submit abstracts for presentation at that conference and consider coming along. Okay, it's with great pleasure that I can introduce today's speaker for our final webinar, Alison Pearce. Alison is a health economist. She's a Chancellor's Postdoctoral Research Fellow at the Centre for Health Economics and Research Evaluation, excuse me, at UTS in Sydney. And Alison has research interests in the costs of cancer, the various costs of cancer, and her PhD was on the costs of chemotherapy side effects. Alison is currently a visiting fellow at UBC in Vancouver, Canada, and that is where she is today, presenting this webinar. So her talk is on productivity losses due to premature mortality from cancer in Brazil, Russia, India, China and South Africa, otherwise known as BRICS. Alison will present for around about 35 minutes, and then we'll have a facilitated Q&A. And the way that you write in your questions is if you move your mouse to the bottom of your screen, a Q&A icon will come up, and then you can type in a new question. So the questions will be viewed and answered at the end of the presentation. Thanks very much, and thank you, Alison.
Great. Thank you for the introduction, Rachel. So as Rachel said, I'm presenting on productivity losses due to premature mortality from cancer in Australia, in the BRICS countries. And this is the paper here that I'm talking about. So I'll have the references again at the end if anyone would like to access it. But I just wanted to point out the relatively long list of international collaborators. I wanted to acknowledge them and their help up front. And so this was some research that I did when I was based in Ireland. I was at the National Cancer Registry of Ireland doing a postdoc for a couple of years. And Linda, Paul, Isabel and I, and you'll notice their names as the co-authors, we'd been doing some work in lost productivity due to cancer in Ireland, and we were interested in the fact that there were a couple of assumptions embedded within the methods we were using, which we thought might not hold true for Ireland because they'd been through a really rapid economic changes over the period of the financial crisis. And so we're wondering whether some of the assumptions that were embedded in the methods we were using might not hold true. We did a little bit of research and saw that some of them did, but some of them didn't. And it got us to thinking about what would happen in countries where these economic changes are even greater. So somewhere where there's rapid development, maybe a developing country which is becoming developed. So I applied for and received a grant from the European Union to go and work at the International Agency for Research on Cancer, which is where Isabel is based. And we have got the grant to do an international project with international collaborators to look at this issue of lost productivity in developing countries. Now, obviously, we had a methodological kind of reason why we were interested in the question, but as we started talking to all these international collaborators, we realised that the project really could provide real value for decision makers on the ground in each of the BRICS nations. So one of the most valuable contributions from the international co-authors was in fact helping us direct the project into the ways that it could be most useful for decision making in the future. So I just wanted to quickly put up the declaration slide. The authors had no declarations of conflict of interest. One of our co-authors, Mariana, was an employee of Novartis, but it was for a short time and it was before we did the analysis. And also to acknowledge the funding that I received. So I was in Ireland on a Health Research Board Interdisciplinary Capacity Enhancement Award. And we got money from the European Union Cost Action, which is the Cancer and Work Network funded my short-term scientific mission. So couldn't have done this without them. So to give you a little bit of background about cancer and emerging economies, worldwide there's about 8.2 million cancer deaths per year, and over 2/3 of those actually happen in developing countries. And what we're seeing is that there are some trends worldwide, such as ageing populations, which also are impacting emerging economies, but things like urbanisation and the westernisation of lifestyles means that the burden of cancer is actually going to increase even more rapidly in developing countries than we're seeing in the developed nations at the moment. And when we think about sort of the developing world, there's really 5 countries which stand out as having had particularly rapid development. So Brazil, the Russian Federation, India, China, and South Africa, which, as Rachel mentioned, are together known as the BRICS countries, have had really large enough demographic and have the economic potential to be among the world's most influential economies in the future. And that's why they're often considered as a group. So they represent over 40% of the world's population, 25% of gross domestic product, and 42% of the world's cancer deaths each year. So the burden of cancer in developing countries and the BRICS countries in particular has previously been estimated in terms of incidence and mortality, so the more typical epidemiological measures of burden, survival, disability-adjusted life years, and things like that. But the burden of cancer really goes beyond the individual level. Cancer also has an impact on society. So no matter what you do, everybody's work contributes in some way to the economy, whether you're a farmer or a teacher, a doctor or a mechanic. And when an individual stops working because of cancer or any illness, this really represents a loss to society, and we call that loss productivity. And it's particularly important in developing countries where workforce and productivity are really some of the key resources that ensure they have this sustained economic growth. So the burden of cancer from lost productivity can provide policymakers with a complementary perspective on cancer control activities. So the typical epidemiological measures like incidence and survival are important, but we think of lost productivity as a complement to those measures. Because developing countries have different demography, different cancer risk factors, and different economic environments than developed countries, all of these can really impact on the economic impact of cancer and make it really important that local decision makers have local estimates of the burden of disease. But at the time of our study, cancer-related lost productivity had only been explored in developed countries, and by the time we published it, only Iran was the single developing country that had its own estimates of the burden of cancer in terms of lost productivity. So our aim was to estimate the value of lost productivity due to cancer-related premature mortality in the BRICS countries for the year 2012. And we chose 2012 because it was the most recent data that we had for all of the inputs we needed across the study. So I'll just talk a little bit about the methods. We used what's called an incidence-based method. So that means we accounted for productivity loss throughout the projected lifetime of people who died from cancer in the year 2012. So we were only looking at premature mortality for people who died of cancer in 2012. And then we used a human capital approach, which is the traditional way of calculating lost productivity. And the human capital approach really thinks about people as having a stream of outputs through their working lives, and it values their time out of the workforce due to disability or death using wage rates. So if we think about someone's lifespan here, on the left in blue, obviously they're a baby, they're not contributing to the economy. Then they might go to school where they might learn skills which enable them to work in the workforce in different capacities. So their school years might influence their productivity in the future, but they're still not contributing to the economy. But then once they get into the purple years, between 16 or 18 and 65 roughly, is when they're in the workforce and their role contributes to the economy. And then after about 66, people tend to retire. And so again, they might contribute to the workforce in unpaid ways, but then no longer have a paid role, which contributes to the economy. And so if we think about in the human capital approach, we have a cheerful factory worker here who's maybe producing widgets. And over the course of her lifetime, maybe she produces 1 million widgets. So to value the contribution of her working life, what we could do is count up the number of widgets she's made, and we know how much each widget sells for, so we can then work out the value of her role to society. But that gets a little harder when you're talking about teachers. What's the value of a child taught? Or an accountant, what's the value of a tax return filed? Or a movie maker or an actress, what are the values of a movie made? So a more straightforward way, or economist way to think about this, is to assume that the competitive market has found a wage for each job which reflects its value to society. Now, there's obviously some arguments against this, and we can talk in question time, if you like, about teachers and nurses would probably disagree with this way of valuing their contribution. And I'm yet to find an economist who can explain the Kardashians and how they fit into it, but that's the general principle. So when someone's diagnosed with cancer, they'll often take time out of the workforce, and sometimes it's temporary, like we see in the graph here. Someone's been diagnosed with cancer at 60 years old, and then they've taken some temporary time off, maybe for surgery and treatment and recovery. But for other people, the same diagnosis might cause them to leave the workforce entirely. So they either retire early or, unfortunately, they die as a result of their cancer. And each of these situations represents a loss to society in terms of the contribution that the individual makes. So the way we value that is when someone takes time off work, say they take 3 months off work for temporary time off work, we take their wage. In this example, we assume it's $1,000 a month and multiply it by the time they take off work. So the total lost, the value of the lost productivity is $3,000. If we have someone who, as I said, either dies prematurely, which is the case we're looking at here, or someone who retires early, then it's the same principle. We take their monthly wage, multiply it by the time they took off work. So in this case, they were diagnosed at 60 and they would normally retire at 65. So we're saying they're 5 years out of the workforce. And so that means the value of the lost productivity is $60,000. Now, it's actually not quite that simple. We also take into account a whole range of factors. So things like workforce participation rates. As people get closer to retirement, they tend to reduce their participation in the workforce anyway. And in some countries, you might have really high unemployment rates. So you might take some people out because they would typically be unemployed if they didn't have cancer. But then we also look at things like wage growth over time. So if we're projecting people's wages into the future, we think about how much our wages might go up over future years. And we also do discounting for future earnings. So we put in a whole lot of adjustments to the model as well. In terms of the data that we used, where possible, we used international data and repositories so that we could make sure the data was really comparable between the BRICS countries. And I'll show you some specifics of the data that we used shortly, but in terms of the actual sources of data, we used GloboCan, which is a cancer mortality database. So GloboCan is a project that uses country-specific data and highly, lost the word, methods which are similar across all countries so that they can estimate cancer incidence, mortality and prevalence. And they do that for 168 countries worldwide. So it's a really fabulous data set if you can get your hands on it. And so what we did was we took the cancer mortality rates and we also adjusted them for country-specific standardised life expectancy. And so that was to take into account the fact that if people hadn't died of cancer, some of them would have gone on to die prematurely from something else. We also used data from the OECD and the International Labour Organization, and that was for a lot of our economic inputs. So things like the unemployment rate and the retirement ages in different countries. And we were fortunate that all of the inputs we were able to get were by gender and 5-year age groups, with the exception of wages. And we tried really hard to find wage rates for gender and 5-year age groups, but actually across all 5 countries, the only consistent measure was average wages at the national level. And then in terms of discounting rate, we used a 3% discount rate, which is based on recommendations for research in developing countries. And they also recommend testing that in sensitivity analysis between 0 and 10%, which we did. And we tested a whole range of other levels of both discounting and wage growth in the future in our sensitivity analysis as well. So I said I'd go through some of the specifics of our data inputs. So if we look here at the demographics and the cancer deaths, between the countries you can see some really stark differences. So China and India, for example, have by far the largest populations. But actually India and China aren't that different, but China has over 3 times as many cancer deaths as India does. And when we look at life expectancy, that's the lowest in South Africa. And one of the reasons for this, I found out that through doing this project, is actually related to the high rates of violent deaths in South Africa, which happen at a relatively young age, and also the HIV/AIDS epidemic, which is ongoing there. Then when we look at local wages and we converted them to US dollars using purchasing power parity, Russia actually has the highest wages of the BRICS countries. But when we look at the wage growth rates, all the countries are really well above the Eurozone average, which was about 1.5% at the time that we did this study. They were really highest in India, which was experiencing a really high period of growth around 2012. Then when we look at the economic inputs around workforce, we can see that women in general had lower workforce participation rates than men, and that the greatest disparity in this was in India, where in the example columns I've presented here for the 40 to 45-year-old age group, only about 37% of women are in the workforce. This is much lower than you would see in developed countries. Then in terms of unemployment, we saw that South Africa had the highest rates of unemployment and India had the lowest rates, which is probably also partly due to that really rapid growth that we saw in the previous slide. And then when we looked at retirement ages, and this was the government kind of set retirement age rather than necessarily a specific actual average retirement age, but the recommended retirement age was lowest for women in China, who could retire at 50 years of age, and highest in Brazil. So one thing to keep in mind was that, consistent with the global trend, many governments across the BRICS countries were looking at increasing retirement ages of both men and women in the relatively near future. So we also did some testing of that in our sensitivity analysis. So now on to the results. What we saw is that the burden of deaths and the corresponding years of productive life lost so that's the amount of life lost between death and the expected retirement age, really varies a lot between countries. And a lot of this is to do with the size of the population, but also to do with the patterns of cancer in each country. So China has over 850,000 cancer deaths among working age people in our year of 2012, while there were less than 25,000 cancer deaths in the same group in South Africa. Obviously, that's a population difference causing the difference in magnitude there. So what we do is look at the total cost of lost productivity then for those deaths. And to make it a bit more comparable, we also look at the cost per death. which takes the population and makes that the denominator so that we're able to take the size of the population out of the estimates. But if we look at total cost first, which is the bars in blue, you can see that because China has by far the largest population, they also have the highest total cost of lost productivity. And that was about $28 billion in US dollars in 2012. But when you look at the value of lost productivity per cancer death, which is the rates in orange, we see that South Africa and then Brazil have the highest losses. So in the case of South Africa, this was pretty clearly influenced by the high wage rates. Remember, they had one of the highest wages in the BRICS countries. But for Brazil, it was a much more complicated picture, and it seemed to be a combination of factors related to the patterns of cancer as well as some of the economic inputs around growth rates. It's also clear that in all countries there were higher losses associated with deaths among males than among females. And this is really similar to the pattern we see when we use this human capital approach in developed countries, because differences in wage rates and workforce participation rates make males look more valuable than females. Now, because of this, I would often not present results of a human capital approach productivity loss analysis by subgroups such as gender. But two things. First of all, our data, we didn't have wage rates by gender and age, so we just used national averages. And so that means that men and women in this analysis do actually have the same wage rates. But it's the workforce participation rates which are really driving some of these differences. So I was still reluctant to present the results by gender. But talking to our international collaborators, it was really important for them to have the results by male and female, because there are some stark differences in the patterns of cancer between the genders in some of these developing countries. And so they felt like it was really important for them to have these results by gender, because decision makers were often making decisions for programs that would be targeted at particular subgroups of the population. So, for example, cervical cancer screening would obviously only be targeted at women, but also patterns of smoking are very different amongst men and women in a number of the BRICS countries. And so smoking cessation programs are often specifically targeted at a particular group. So we present the results by gender, but I would just say to interpret them with caution. For example, China, if you look at the graph, has almost twice as many cancer deaths in men than women, which leads to a huge difference between the genders, which you can see. But in India, women actually have very similar numbers of cancer deaths to men, but because of their low workforce participation rate, they have far lower productivity losses. And so you don't see the difference as much. So then we had a look at the different productivity losses by different types of cancer across the countries. And again, we can see some pretty striking differences. So this graph shows the contribution to lost productivity of 10 important cancers. So they're cancers that we identified either because they had high rates of incidence or mortality, or they were particularly interesting for one of the policymakers in a particular BRICS country. Now, what jumped out to me straight away when I saw this graph for the first time was lung cancer, which is in the light blue. It's obviously important across all the countries, and I've got another slide about tobacco-related cancers shortly, but you can see that lung cancer is a particularly big problem across the countries. Now, stomach cancer in red, which is down towards the bottom of the graph, also has a high impact across all of the BRICS countries. And actually about 70% of stomach cancers worldwide occur in developing countries, with H. pylori an important cause, as well as diets, particularly ones associated with a higher consumption of salt. So that's what you're seeing there. Then when you look at at China, one of the striking things is the liver cancer in purple, is that big block in the middle. And speaking to our international collaborators there, it's really related to hepatitis B, which is highly prevalent in China and in particular in rural areas. And that drove one of our other sensitivity analyses, which was to look at the differences between urban and rural populations in China using some local data that they had available. We also see that countries that have high rates of HIV infection are also likely to be countries which have high rates of cervical cancer, which is shown in brown towards the top of the graph. And you can see this in South Africa because despite India having nearly 20% of all cervical cancer cases worldwide, again, that issue of low wages and workforce participation rates amongst women means that it's not reflected in their workforce and lost productivity. And then finally on this graph, I think one of the other things that's really interesting is obviously the major contributors to lost productivity in each country are important, but it's also really interesting to note what's not in the graph. And that's two of the largest contributors in developed countries to lost productivity, melanoma and prostate cancer. You can see that these are hardly seen at all in the BRICS countries. Prostate cancer is in the bright green, right towards the top of the graph, and you can see a small sliver in a couple of countries, and similarly melanoma is in orange, and that also has very small rates across each of the BRICS countries. So I said I'd talk specifically about tobacco-related cancers, and obviously lung cancer is a big contributor. Over half of men in both China and Russia continue to smoke, so I guess high lung cancer rates aren't surprising. Although we should note that in China, high rates of lung cancer are also related to high levels of air pollution. Actually, when we looked at the cancers related to tobacco, they contributed to around 1/3 of the total lost productivity across all of BRICS countries. So tobacco really is a high area of need or tobacco control in some of these developing nations. India also has quite high levels of tobacco-related productivity, not necessarily because of high smoking rates, but because of the mortality associated with lip and oral cancers, because they have a lot of chewing tobacco. The other interesting thing to note was Brazil, which had relatively smaller levels of tobacco-related cancers, and we're actually expecting that to drop quite significantly in the coming years because they have had very successful anti-smoking campaigns in recent years. So what we're hoping is that in Brazil you'd see the size of the tobacco-related cancers contributing to lost productivity decreasing, in particular in Brazil. So I've mentioned the sensitivity analyses as I went along. So we used sensitivity analysis to test a number of assumptions within our calculations. So we looked at using some local data to look at urban and rural differences in China. We also looked at increasing the workforce participation rates amongst women in India. So if women in India, 1% per year more women participated, what difference that would make. And we looked, as I said, at changing retirement ages in the future, which was a common theme across policymakers in all the BRICS countries, but particularly in China and Russia, which had relatively low retirement ages to start with. And as I mentioned, we adjusted growth and discount rates at a whole range of different levels. And I'm not going to go into them in much detail because really none of them resulted in any major changes to our findings. Obviously, if you increase the workforce participation rate in India, for example, then you end up with higher rates of lost productivity amongst women. So there was nothing there that was unexpected or that changed our thinking. So the next slide is really the limitations, and this was where we started thinking about whether the human capital approach really is appropriate in developing economies. And I guess what we saw was that some of the equity concerns that we have about the human capital approach and how it's applied are really amplified in developing countries because there are greater equity differences. So, for example, the gender differences around workforce participation rates in developed countries, it's a concern, and it's not ideal to show that men, or for it to look like men are valued higher than women. But the differences are relatively small. But when you come to a country like India, which has these huge differences between men and women, then it really does become quite, the potential for it to be quite misleading. There's also big differences in terms of equity amongst cancer rates in different parts and different subpopulations. So the urban and rural differences in cancer rates in China, as well as Brazil, were of particular concern to local policymakers. We weren't able to capture that in our analysis, but it does suggest that if you were able to, you would have similar differences where some of the differences you see in the results might not reflect equity differences that you see in real life. Then there's also some assumptions around some of the employment data that I think is less robust when you're looking at a developing country, particularly because the informal economy and household production and unpaid work are really much more important in many of these developing countries. So there's obviously subsistence farming, there are family businesses which are much more common, which all fall into this sort of informal economy. And the low rates of workforce participation amongst women don't reflect the fact that these women have really highly valued roles in society, which are normally encompassed under household production, but which really do have an economic benefit in a rapidly developing economy. So I think those tend to be missed out when we're looking at the human capital approach. And then finally, the thing that we struggled with probably the most was the availability of data in some of these countries. So particularly when their economies are changing so rapidly, having really access to timely data was very important, but many of them don't have the resources to be doing real-time collection of cancer rates, for example. And so some of the data was much slower to come in than we were used to when, for example, at the Irish Cancer Registry. GloboCan, as I said, is a fabulous data resource, but when data isn't available, it has to do estimates. And so whilst we're fairly confident in the robustness of the data, it does tend to be countries which have less resources for things like cancer registries where they're doing the most estimation. And a great example of that is China, where I think it's between 1 or 3% of the population is included in the cancer registry. So that's a very small percentage of the population to be hoping that it's representative. On the other hand, it represents a huge number of people, so it's much larger than many of the other population-based cancer registries. But it does raise the question of how representative the data might be at a national level. And then finally, one of the things that we really struggled with was that our international collaborators were so engaged and really interested in the research and wanting to use it to inform policy at their local level. And we were happy to do local level analysis where we had the data, but unfortunately local data and data in various subsets wasn't always available, and so we weren't able to do that. So that's some of the challenges, I guess, of applying this method to a developing economy setting. So despite all of these problems, I think our results highlight some important things. So one is the importance of cancer prevention activities in the BRICS countries. Smoking reduction, for example, is the largest area of cancer investment in developing countries so far, and it's clear that that's important and should continue. It still strikes me as amazing that over half of men in China and Russia still smoke. And in India, we're actually seeing the age of people starting smoking dropping over time. And so for them, the onset of tobacco-related illnesses will also reduce and will almost certainly result in higher productivity losses in the future as younger people who have more time to contribute to the economy end up getting cancer earlier. But our analysis also suggests the potential importance of vaccinations, particularly for hepatitis and HPV. Now, both of these are relatively cheap to purchase and easy to administer. Obviously, there's some resourcing requirements to have a systematic approach to that, but our results certainly suggest that they're an area which could have implications for improving the levels of productivity in these countries if they were addressed in the future. In addition, there are some cancers which have high mortality rates in the BRICS countries, but which we would normally consider treatable relatively easily in a developed country like Australia or Canada. So investment in earlier detection and improved treatment availability could bring about economic returns in relation to increased productivity. But again, there's problems with availability of resources to do some of that. and prioritisation. And so we would suggest that the BRICS countries really prioritise prevention over treatment and probably vaccination as well. Then it's also important to recognise that because the BRICS countries are developing so rapidly, or certainly they were at the time of this study, some of them have slowed down a bit and others have taken over, but in general, if you have a very rapidly developing economy, you could end up simultaneously facing the burden of cancers which we typically think of as a developed country's problem, such as prostate cancer or melanoma, on top of the burden of disease that we typically associate with developing countries like lung cancer and liver cancer. And this could end up with, I guess, a pattern of disease that we haven't seen before and which could be quite challenging. Because, of course, a number of these countries also face problems, in particular around communicable diseases, and are still dealing with issues and managing those. So there's still a number of issues regarding the methods for estimating lost productivity and how they can really be most appropriately applied in an emerging economy context. But we felt that as the first estimates of the value of lost productivity related to cancer in the BRICS countries, our results really, we hoped, would provide decision makers with an important additional and complementary perspective for prioritising cancer prevention and control activities in their local setting. So I wanted to just spend a couple of minutes at the end talking about what happened with this research and how it came to win the prize through Health Services Research Association. So this is an infographic type thing that I put together to show the media coverage that we got. So we had a really strong media strategy for this paper when it was released. So it was published in Cancer Epidemiology, and each of the co-authors had a version of the press release which had specific data for their local context, and they were encouraged to send it out to not just media outlets but also clinical and policy people that they had connections with, and that resulted in a really fabulous media attention. So we had, I think it was over 40 press mentions in obviously newsprint and online news repositories, as well as radio interviews, television interviews, and invited speakers at symposiums. And we also did a specific article related to our paper in The Conversation, so it was released on the same day, and that was actually pitched to The Conversation Africa because we felt like they would have a really specific interest in it, and we had over 6,000 readers in The Conversation for that article, which was really encouraging as well. So the paper is now in the top 5% of all research outputs scored by Altmetrics. And we're really pleased to see that every now and then we still get a little flurry of things, and our co-authors internationally are still being asked to give presentations and to talk to policymakers about the research, even now, nearly a year since it was published. So we also had a policy engagement strategy that went alongside our media strategy. So as I said, all our co-authors were sent local versions of the results. And if people had a particular policy question that they were interested in at their local level, then we would do some additional analysis for them. So, for example, in China, one of the departments of oncology was looking at gastric cancer and really wanting to make a case for why they needed funding to set up a specific service. And so we were able to provide them with some data that was specific for them to be able to lobby policymakers for some additional funding. We also tried to link our results with other events that were happening worldwide. So, for example, the new president in South Africa announced a really big new cancer prevention initiative, and we were able to get our research in with the news there, which meant that it had a much wider policy relevance, or people who were making policy in that area were suddenly aware of our research where they might not previously have been. And as a result of our policy engagement strategy, we got a number of invitations to present at both policymaker forums, including in India and Russia, and at patient advocacy forums in Brazil. So we were really excited about that as an opportunity to kind of engage with policymakers and tell them a little bit more about what we've been doing and why we thought it might be helpful for them. The research has been referenced in a number of reports, including to the UK government, the South African Ministry of Health, and the Ministry of Health in India. So that's been really rewarding. And we're now going on and doing some more work. There's a paper which is under review at the moment with our Russian collaborator and his team, using some local data to replicate the results, but look at some specific subgroups and some specific policy questions that they're very interested in. And the Brazilian collaborators and I have a grant application currently under review, again looking to replicate the results for Brazil and dive a bit deeper into some of the local issues that they're particularly interested in. So I just wanted to once again thank the international collaborators. They really were engaged and really valuable in our research, and also to thank the funding bodies that made the research possible. And this is references if anyone wanted to access the full article, that's at the top there. There's also the conversation article, which we published alongside the journal article. And then in case you're interested, I did a blog post which is very similar to the conversation article, but I also did a blog post about the actual award, and it just has a little bit more information about the process of actually writing the paper and how that went, because it wasn't one of those ones that just comes about really easily. So I'm happy to take any questions if anyone has them, or if people want to get in touch with me later, they're very welcome. But that's it.
Terrific. Alison, that was fantastic. Thank you very much. A really detailed analysis across a range of countries. So many different variables, so many data sets, limitations with data sets, but I think you presented that really well, and congratulations again on being such a worthy prize winner. We have two questions that have been typed up, and I just encourage people at this time to go to the Q&A button and type in your questions. Alison, I might read the questions out and respond to them. So the first one is from Nikita Khanna. What are the different professions taken into account in the national wage average, if known, and does it include blue-collar workers? So I guess for each of those participating countries, whether there are particular occupations included or excluded. So it's not particular occupations, but it's definitely particular types of work. So it's really only the formal economy, which is, the vast majority of what we would consider a job in a developed country would be taken into account. So it definitely does include blue-collar workers, but it wouldn't include people who are in the informal economy. So people who are being paid cash in hand, for example, which in some countries happens more often. In some of the BRICS countries would happen more often than we would be used to seeing here. And it doesn't include things like family businesses or people who are subsistence farming, or even farming and selling, for cash at their local market. So there are definitely some groups of the population who wouldn't be included and who probably would have very different wage rates. So that's definitely one of the limitations of our data. We have got the idea to go through and look at unpaid productivity and informal economies and lost productivity, but we haven't got that data off the ground because it's much harder to find than national averages. But right, that actually was my key question. Is what about all that unpaid work? I guess this just is about formal employment, formal paid work that is captured within those databases. What would be your approach, do you think, to try and include unpaid production, particularly from women?
That's something I'm really interested in, and I'm trying to do it even for Australia at the moment. So there's a couple of different approaches that you can take. We have time use surveys in Australia, so we can see what proportion or how many hours a week the average person spends on unpaid productivity activities. So things like household chores, volunteering for different organisations, childcare, for example. So we can use that as an estimate and then again value it either with what their average wage would be if they were working, so sort of an opportunity cost approach, or we could just say sort of a replacement cost approach, how much would it cost to get someone else to do that childcare or that housework or that volunteer work. So that's the general approach that we would take. How you apply that in a developing country, I think, is difficult just because you have all the same problems, but they're compounded by difficulty finding data and the real equity differences that you see across the population. Mm-hmm. So I think it would be really interesting and it would be really valuable because I think it would give you a much better picture of the true burden of disease.
Yeah. So just following on from that, there's a question about friction-based approaches measuring productivity. And the question is, could you speak to the friction-based approach and whether you consider this reasonable?
So despite being a researcher who's done quite a bit of research in lost productivity, I wouldn't say I'm particularly sold on any one method in particular. We do actually include in the paper the years of productive life lost, specifically so that if people did want to use the friction cost approach, they could go ahead and do that. And for people who aren't familiar with the friction cost approach, it basically says the human capital approach totally overestimates lost productivity because in reality, if someone leaves the workforce because of cancer, they get replaced by someone else. No one's actually irreplaceable in their workforce. And so they only count that friction period, the time until the worker gets replaced. So you end up with much smaller estimates. And I've done some work comparing human capital approach and friction cost approach estimates in cancer, and it's about 3% normally, the friction cost estimate. So we did think about it. By calculating years of productive life lost, you could do the friction cost approach with these data, except that you need so many inputs for the friction cost approach about the economic situation, how long it takes to replace a worker, that sort of thing. And really there's very few countries in the world that have local data detailed enough to be able to calculate the friction period. We don't have that for in Australia, for example. I'm working on trying to estimate that at the moment. So we just had no way of being able to do that for these developing countries. Although our initial plan was to do both the human capital approach and the friction cost approach and compare them, but it was just too hard. It would have required so many assumptions that we just weren't confident enough. Yeah.
Okay, though that it sounds very reasonable. Another question in terms of education of participants, I guess people captured in this study, were you able to account for education differences? And if so, how did you account for them?
So the short answer is no, we couldn't. I guess in some ways it's kind of captured by the wage. So because it's a national average wage, it's putting everyone together and pooling them, and so it averages out the fact that people who have higher education would have higher wages. Yeah, we haven't actually been able to deal with that. And typically, I think some people have captured education and looked at, average levels of education and wages at different age groups and genders. But normally we just use age and gender as a proxy. You would assume that as you get older, you become more educated, whether that's formal education or just more experience in the workforce, and therefore your wage tends to go up. So no, we haven't really accounted specifically for education.
Okay, and another question from Karsten here. How should funding agencies best take into account productivity costs in health technology assessment? Is there a nice, neat cost per patient per condition?
Yeah, so you can get a cost per patient for lost productivity associated with an illness or a disease. I don't think I've talked a bit about some of the different problems and the assumptions that maybe don't hold true. So I think I certainly wouldn't advocate that it's used solely as a decision maker input, but I think it can be really, it can provide a really different perspective. So instead of just looking at which one's the most common, it really gets you to think about who different conditions occur in. So if something's happening in young people, then that has a much bigger impact on productivity loss than if it's happening in people who are 75 years old. So I think it's just a complementary perspective. In terms of how you incorporate it into a health technology assessment, I think it's probably never going to be in the base case. There's a few countries where they recommend it, but not many. But I think increasingly we're seeing countries recommending that it forms part of a sensitivity analysis. And I think that's a really nice way of approaching it, particularly when we're so unsure of the best methods to use. There's still this debate around human capital approach, friction cost approach, there's willingness to pay approaches as well. So I think until they're established a formal standard method, then having it in the sensitivity analysis is a nice way of including it, especially if you've got a disease or an intervention which you think might be particularly impactful on people's productivity.
Okay. I've got a couple of questions. If anyone else is thinking of some, if you could please type them up. I was wondering about caregivers or family members, the impact of cancer of a family member on the production of the household, and whether, I know that's not something you're able to look at in this particular study, but whether you have any thoughts about how that might be done on a population level. Yeah, the question is, can you include the productivity losses from family caregivers into an analysis like this?
You probably could. I wonder if by including unpaid productivity or including caring as an unpaid productivity cost, you would capture that there. So you would be capturing that not at the level of the person who doesn't have... Yeah, I'm sure you can. You might just need some creative thinking around whether you attribute it to the person who has the disease, because obviously you don't want... It's not them not doing caring anymore, it's other people doing caring. But if you could use the same data to be able to extrapolate from one group to the other, maybe you could do it that way. Or to simply... It's hard to say at a specific disease level though, because all the data we have is just average time use. So
I guess even if you were to, if there were, national surveys or cancer surveys that asked people how much time they took off work to care for somebody with cancer, might be a start.
Yeah.
I've seen some recent publications about a better cancer experience and end-of-life experience return to work for carers sooner. So that bereavement, the bereavement stage of cancer as well. Anyway, I just thought it was of interest because there certainly is, loss of production from other individuals.
Yeah, absolutely.
We have another question from Maria Batista. Is cancer modifiable disease in these countries? Is cancer a modifiable disease in these countries? Beg your pardon. Otherwise, did the data capture only public sector cases and therefore underestimate the costs?
So yes, I think a number of the cancers that we see that have a big impact on productivity definitely are modifiable. So things like vaccination, prevention, I mean, clearly anti-smoking campaigns in a couple of those countries could be really successful or really impactful. I'm not quite sure about the public sector question. I'm not sure I totally understand that.
Because all of the cancer cases that are registered through GloboCan are based on either mandatory reporting or a cancer registry.
Yeah.
It would include cancers detected through public or private systems.
Yeah, they should include public and private systems. And GloboCan has quite a rigorous method for ensuring sort of comparability across countries. So they would have taken into account if, for example, a country did only have public sector reporting, then they would have a way of estimating and extrapolating across the country to be able to include private as well. So yeah, I'm not sure of the specific details of how GloboCan does that, but I'd be confident that they'd have a pretty rigorous way of doing it.
Yeah, okay. Final question. I think your work demonstrating impact is really terrific, and obviously it's global. How will you know whether, tracking over the next few years, how will you know the impact that this study has had? You've obviously had a good dissemination, strategy, and your local country investigators have worked with people locally. But how can you track the impact of a paper like this?
I think that's really hard. If anyone has any suggestions, I'd love to hear them. I mean, I think the main thing we're doing is staying in touch as a collaborative group. So even though there's a couple of us who are still working together on various bits and pieces, but some of them I probably won't get the opportunity to work with again. But we're definitely, as a group, making an effort to stay in touch. So we have a sort of central document where people can add if there's ever a media mention about it, or they get asked to speak about something to do with the research. So we're trying to track that. We also have some contacts at the BRICS kind of central organisation, and so it's been interesting to see them. We sent the research to them and a couple of follow-up pieces. So we've been trying to see how it sort of trickles down from them to the different countries as well. So I think if we can keep that central BRICS contact as well, then that'll be really valuable. But it's mainly just talking to people and anecdotal evidence.
Yeah, no, I think it's I think it's a challenge, and I think you've demonstrated a really nice case study of impact here. It's something that all academics are required to present, and I think what you've done has certainly been impactful and will continue to be so. So I'd just like to thank you very much, Alison, for a wonderful presentation, and your contact details are there if people would like to talk to you further. Do you have a final slide?
I do here. There you go.
Oh, terrific. So just to remind, to thank everybody for attending and for their engagement, and to remind people that the Health Services Research and Policy Conference is on in December next year in Auckland, and the theme is addressing health service inequities to improve health system performance. So on behalf of the association, I'd like to thank Alison and Sarah, as well as everyone who's participated, and we look forward to seeing you at the webinars next year.
Great, thank you.